Bell.
Here.
Mary Jane Lewis.
Here.
Okay. Miss Mouse.
Yeah,
Butch Mouton.
he's gonna be late, but he's coming.
Okay. Clyde
Here.
Stansberry. Shannon Thomas. Okay.
Shannon Thomas,
Is that her oral name?
she might be, what's my
Shannon Thomas is the LPAE,
Yeah,
right,
she's
Ms.
the
Mel?
one, she's the one that's gonna be replaced.
Right.
Oh, she's the one to be, okay.
Yeah.
I had a couple of lists, I couldn't
Right.
remember. Okay, so we can scratch her. Coach Thrower, almost over at school, so. Miss Bartlett. Vicky So.
She's in Florida.
Oh, jealous. Small, okay.
Hello, Miss Mary.
How are you?
How's everybody?
I'm
good.
You all ready?
You're ready?
Motion to accept all that?
Nope.
Okay.
Before we start the agenda, I want everybody to know that obviously Keith is not here. Those of us who've been around a long time are going to miss him dearly, but he's no longer in transportation. He thought, yes, a health issue he thought was temporary, but it's permanent. So he now has a different position. So I've asked Ms. Morrison to announce that vacancy at the next board meeting, and I've been in touch with the president of the Bus Drivers Association, Laura, and they'll have a substitute, but nobody will be able to fill his shoes. We all feel that way. All right, we need a motion to approve the agenda.
I'm going to take motion.
Clyde,
My second.
second, Shannon. All those in favor?
Aye.
Anybody opposed? Approval of the minutes that Trish distributed. I need a motion.
Miss Mayor.
Mia, is there a second?
A second.
Clyde, anybody? All those in favor?
Aye.
Anybody opposed? Next thing on the agenda is the election of a new member. Shannon Thomas has a new position and said she could not devote the proper time. So Mrs. Morrison announced the vacancy at a board meeting, and I have one person named Chris Miller who has expressed his interest, and that is who the LPA president called me and said it was their representative. So do I have a motion to approve Chris?
I make that motion.
Oh, I'll second.
And Don
I'll
seconded.
second.
All those in favor?
Aye.
Anybody opposed? I will contact him and let him know. He's been to one of our meetings before. Next, the ESSER funding reimbursement. Is that Trish?
Yes, ma'am. So I wanted to give you some good news with regard to the ESSER funding. It is coming through, $929,248 to help build your reserves. It's due to the COVID. They're issuing it with regard to the Elementary and Secondary Emergency Relief Fund. We've gotten information from the director, Ms. Latika McGee, that the funds are coming. We just don't have all the details with regard to when they will arrive, but it has been approved.
That's wonderful.
So it's great news.
So as part of the grant process to ESSER, so we applied for, we pulled the, what were the dates, Trish?
From 4/1 of 20 to 3/31 of 21.
That was the expense that the plan paid out for COVID. So we put it in the application with 23 other pages of items for, to use ESSER's money fund, and it was approved. It's a grant issued for reimbursement for reserve.
Wonderful.
So
We
it goes
can
in the
use
fund balance?
Yes, ma'am.
every penny.
Yes,
we can
ma'am.
use. Next item on the agenda, Mr. Fontaine from Hub International. We got his report in the mail, and we have it here. Lynn, I'm going to ask you again, if you don't mind, because we've got several new numbers. In fact, I should, for those of you who don't know, Phyllis Bartlett was elected at our last meeting. Melanie Abier as well, but she is ill. And Vicki, whom we all know, is out of town. Those are our new members. So
And just to
if
make
you
a
could-
clarification on the previous comment about it will go to fund balance, but it will go through the income statement. So it's not just going to go to fund balance, it's going to show as revenue, so you're going to see in the income statement. To get to fund balance, it has to go through.
I
revenue.
understand, yeah,
So,
that makes sense.
We can't just put it to fund balance.
But it's
I
gonna get to fund balance.
It'll get to fund balance.
Yes,
It'll get there eventually.
I just jumped over the big consent here.
Lynn, if you don't mind, could you read the summary page first? And then we'll go back and see how you got to that summary. Because sometimes we get lost in all the minutia, and by the time you get to the summary, we kind of don't have the big picture. So if you do that, I would appreciate it.
All right, and that is on page 29.
Correct.
All right, so going over this bullet by bullet, your participations remained real stable. It's decreased less than 1%. Employee only is very stable, while the dependent participation went down 1.2. If you remember from the past, that's actually a good thing. Membership is the number of bodies in the plan. Participation is the number of employees and retirees in the plan. So when membership goes down, that's less dependent participation, which is a good thing. Membership remains stable, decreasing less than 1%. Medical claims per employee per month remain stable, decreasing a little less than 1%, $499 versus the 501. There are currently 1,600 members with payments between $2,000 and $20,000, and that's totaling $9,284,000, and which equates to a per employee per month figure of $188.67. For that same period of time the previous year, there were only 1,333, totaling $7,521,855. So you can see there's an increase there in the 20,000 to 20,000 range. When we talk about 20,000 to 50,000, we're comparing 116 members to 126 members the previous year, and a 5,000,001 figure to a 3,000,008. So those two bullets point to the same period of time, and that period's 1/1 to the end of September, comparing 21 to 20. So we can see that we had a lot more utilization in the small to mid-sized claims. Then when you look at the next bullet, which compares the larger claims over 50,000, 75 this year compared to 80 last year, but look at the number, 7,397,000 versus 10,618,000. So like I've always tell you, there's a theme to all of this reporting. And basically in 2019, we had some pretty high costs and increasing costs. In 2020, costs came down a little bit because of the stay at home, and then you've got some pent up utilization here going through the plan. But we also have a lower cost on our high cost claims. So if you look at the difference in those numbers, the deltas between the two numbers, it almost washes, and that's why you have just a small difference in your medical claims of just 1%. Prescription drugs increasing 4.9%. I'll tell you that's a very low number because most plans are increasing double digits. If we would not have done the work that we've done on the prescription drug program, you'd see a much bigger increase than that. Plan reimbursements increased some 24.5%. Part of that, our large part of that, is the additional reimbursements that we've garnered on the prescription side. Not a real big difference in the reinsurance that we've collected, obviously, because we've had a decrease in our larger claimants represented in the bullets previously mentioned here. Total claims increased 1.6%. Plans claims net of reimbursements decreased 1.6%. So claims running about the same thing, stable, more reimbursements. The enhanced plan claims per month are 30.3% higher than the basic and 145% higher than Blue Sabre. Total cost is down 1.9%. So basically we have stable participation. We have very stable claims right now and compared to the past, albeit increased utilization that is offset by a lower number of high-cost claimants. But the total plan cost is decreased because we have higher reimbursements into the plan. Plan cost net of employee contributions is down about 3.2%. Why? Because we increased the rates on January 1st. Now, I will tell you, the 3% increase, we haven't really gotten 3% increase in funding, because when we look at those demographic numbers at the top there, and you see that we've actually decreased in our participation, but more so on the dependent side, you get a little less contribution in that. So it's really about 2.8 compared to 3. The employee, if I remember right, the plan members' funding increased about 1.9%. So inpatient, total cost of the plan decreased, net of employee contributions down to 3.2. Inpatient, and this is indicative of lower high-cost claimants, is down about 20%. Utilization going up. Outpatient increased by 14.5. Professional, which is your doctors and diagnostic testing, all of that, any type of physical therapy, things like that, 14.4% increase there. Generic drug utilization remains at 85%. That 85% only represents 14% of the total drug spend. Our top 10 medications that only represent 2.4% of the total of the total number of prescriptions represents about 30% of the prescription drug cost at 29.3%. High cost medications increased 3.4%. PPO savings remain competitive at basically 70%, 69.8%. Network utilization is still high at 97.3%. Approximately 4.6% of the plan members are responsible for 63% of the claims, 18.3% responsible for 85.6%, and almost 82% of the plan members have less than $2,000 of claims, and that only represents 14.4% of the total claims.
Does anybody have any questions about
I
that?
have a question.
Carol?
The question that was posed to me with Silver Script, you can't use a coupon. Let me give an example. If I'm using Silver Script, I'm getting my medication, and I could use this, I'm gonna call it coupon for lack of a better terminology, have this coupon where that medicine, because of the coupon, I would pay $5 per month, because the coupon would pay whatever my copay would be, and minus whatever, and my total would be $5. Silver Script won't allow that. So which means the same person who could have paid $5 a month for a prescription now has to pay $70 a month because they won't allow the coupon. So why is that?
That's the federal laws that have to do with the Silver Script type program, because it's all of that's governed by CMS. You can't use coupons.
But wouldn't it be beneficial? I mean, it would cost Silver Script less because whatever company is covering that coupon, so that member wouldn't, I'm gonna give that same member per month for 3 medicines, she's paying $210. She has a total of 8 medications for a month, but 3 medicines are costing her $210. So where's the saving for people like her? It could be that coupon that she's not allowed to use, because it would reduce it from $210 to maybe $15.
The CMS programs do not allow you to use a coupon. There's really nowhere around.
And there's nothing else we can do to help reduce, and that she's not the only one. I know my prescriptions have gone up. I have some that have gone down, but I have a lot that went up. So what can we do? This was supposed to be a cost-saving measure. Is it for members who pay into the plan? Because I'm not seeing that.
It's a cost-saving measure to the members as well as the group, and the vast majority had savings. They were very, there was a small percentage that had some increased costs. And we went over all of that when we went through.
And I'm preaching the same thing, because it hasn't changed since we started. It's the same song. So I want to see next year how much more my medications will go up. They're not decreasing, it's only rising. And that's with the cost of everything, I understand that. But I'm not seeing that savings. Maybe the board is assuming the savings, but it's coming out of my pocket.
There's several members that are seeing the savings because several of their prescriptions are at a lower cost than ever.
I have a follow-up question. So the CMS programs don't allow coupons. Do they also not allow, are they also ineligible for copay assistance programs that are available? Is that the same thing?
Same type of.
A coupon is synonymous with a copay assistance program?
Coupons, copay assistance.
Okay.
Yes.
So if you're on Silver Scripts, you cannot use RX benefits for, not RX benefits, the RX,
Good doctor, good.
good RX, you can't use that if you're on Silver Scripts.
No.
You could use a good RX to find out where to purchase the
But you
medication.
can't use the
That's
coupons
what
from
good
the
RX,
RX.
good RX not only can steer you to coupons, but good RX shows you where the medication is at the least cost of the pharmacies in a certain
You
locality.
can use GoodRx, but you can't use
The
your
coupon.
prescription plan.
Correct,
That's how I'm gonna say it.
correct.
I
You
think-
can use it,
Yes.
you just can't run it through the insurance program too. So
Yeah,
if you
yeah.
use GoodRx, you get the discount through GoodRx. It doesn't accrue towards your out-of-pocket on the Silver Script or the RX benefits plan.
So if you are on Silver Scripts, as this person is, she can use the coupon, she can go use,
No,
and
no.
just not run it through the
You,
school
I
system?
mean, specialty medications, first of all, you're not gonna see that on a GoodRx. GoodRx is normally for your lower cost generic medications. But if you run a prescription, let me just give an example. Let's say you have a low cost antibiotic, something really cheap, right? And you run it through GoodRx, sometimes you can get it a little cheaper. But if you run it through that plan, GoodRx, it's not gonna go towards Silver Scripts or RX benefits for that matter, and it doesn't accrue towards your out-of-pocket maximum.
But can you do it, is my question.
Sure.
Yeah,
Sure,
there's nothing
you
that
could not
says you
use
can't.
your insurance.
Right.
Yeah, you have to count.
And Ms. Mount, also, the other thing about the RX benefits is the formulary, there's no formulary. So where you might, we give a 30-day supply and in our formulary says 15, you can run it through the good doctor and actually get your 30, and it could be cheaper than running it through insurance. I know the formulary changes too.
I think in the future, it would be useful to just have that information, because I did not know that the programs like SilverScript did not allow for coupons and copay assistance programs. I think that that information would be useful to share with the committee in the future when we weigh those decisions.
We had not discussed
did not know.
coupons before,
Nobody knew.
to my recollection.
And I just became aware of it because it was asked me that question. I went, I don't know, but I'll ask. I just see it as a saving that we're losing out, and we don't control it, I understand that. But I can think of when my husband was on this medicine that was $15,000 a month. He had this program that paid for his medicine. Thank God our health plan didn't pay for it. So I'm just going, how many other people are in that same area where they could have this program, but SilverScript won't allow it.
Sure.
Just food for thought.
I know Butch Mouton has done
Yes, yes.
a lot of research. He's coming
Yes.
tonight and will be here later.
So we go back to the beginning of the
Yes,
report?
yes, sir. Nobody has any questions?
We're at page 1 here.
Then before, you don't have any savings recommendations. There's no savings strategy here.
Ma'am?
There is no savings strategy.
Yes, after the report.
It's just not in this booklet, or it is?
Yeah, it's
Page 30. Page 30 and after that, 31, 32, 33. You've got
So
some.
the savings strategy is your proposed benefit management of 2 million and the 1%? Okay.
When we met at the last meeting, we talked about the saving strategies of the prescription drug program and negotiating the PBM contract. And then we also were requested to show what premium increase would garner if we were to increase rates. That's not on the table at this particular time. Do y'all want to go through the report, or you want to go through the?
No, let's go through the report. I just did not see any pages, so thank you.
All right. So back to page 1. Tying in with all of the summary, you can see at the top, this is January through September, and participation very stable. We're actually down a little bit on the participation through Blue Cross, up a little bit on the retiree plan through Humana. Total participation almost equal, 5694 compared to 5690 is our averages there. Medical claims paid at 24,557,000. Prescription drugs just a little bit over 16 million. Our total gross claims through September of 40,573,000. Plan reimbursements 5,264,000 through September. Retiree drug subsidies right under $1 million for a net claims figure of 34,310,000. Our fixed costs right under $3 million at 2,947,000. Retiree premium 457,904. Our total plan cost of $37,716,051 dollars there, and you see that computes to an average on a per employee per month basis of $736, which represents a 1.9% decrease from the average of $750 of 2020. From a funding perspective, we're talking about total funding of $38,152,478. Net employer cost, when we take into account subtracting out the employee and retiree contributions, just the board share, $26,285,401. Our budget loss ratio at 98.9%. Surplus right now at $436,427. Our average cost, when we look at it since 2016 over a 5-year period, our average cost has increased by less than 1% a year. Okay? Folks, that's phenomenal on a plan this size or in any plan. You obviously, from a funding standpoint, you increased rates 3%. January 1st, prior to that, it was all the way back to July of 2017. The next page shows it a little more clearly when we're comparing to previous periods because it breaks it down on a per employee per month basis. Obviously, we've talked through the participation part of it. You can easily see on the medical claims, 501 to 499, down that 1% or so, less than 1%. A little bit of an increase from 310 to 325. Total claims going up only 1.6%. Our plan reimbursements from this year to previous year are up 23.3%. 107 compared to the 86 and then the retiree drug subsidies, 20 versus the 17. Gives us a net paid claims figure that's actually down 1.6%. Fixed costs very stable, actually down slightly. And that usually increases every year, but if you remember, we negotiated very well on the fixed costs last year, this year as well. Total Blue Cross plan costs down 1.6%, 757 compared to the 659. Once again, we had a 7% decrease on the Humana premium, 225 versus the 242. Total plan cost at that 736, which is 1.9% down. Funding, you can see about a 2.75% increase there. Net employer cost down 3.2, and then of course the surplus has a $9 figure on a per employee per month basis.
Lynn, I do have a question. I know that's January through September. Is there any reason to believe that we may be surprised between October and December, or do you think that's pretty much a trend? COVID is down, which should help our plan.
Oh, she's asking.
I told y'all, I promised y'all
Oh,
I
I'm
would get a
sorry.
hearing aid before
It's
the
me.
last meeting
I'm
and then
sorry.
a hurricane.
No, and I have a hard time
Okay.
understanding
So,
people, so I certainly.
You're asking, what do you think the next few months are gonna be?
Yeah, is this a trend,
So
you think, or are we
here's what we're
expecting
seeing.
any huge surprises?
I still think we're going through pent-up demand because the report, page after page, shows high utilization right now, and higher than we had, obviously, in 2020, okay? Because a lot of people, we were going through a stay-at-home order and things like that, and that pent-up demand is going through. So when you see in further pages, you're gonna see, circulatory stuff, and the fact that the professional component went up, the inpatient component went down. So large claimants, which has always been what drove the cost of the plan, okay? Whether we had a good year or a bad year, that's actually down. And quite thankful for that, because that has offset the increase in utilization that's come in from people just going to get what they needed done with the economy opening back up and that type of thing. So we're going through that, but we're still at this point with, I measure this on what I see every week, and when we're looking at weekly claim runs of 600, 660, 670, sometimes 700, a good claims run for you guys on a weekly basis is under $500,000, okay? And we get those from time to time, but I think we're still going through. So to answer your question, I think that we come very close at the end of the year to breaking even, okay? Now, you're also going to have to note costs are increasing going forward. Cost of healthcare is certainly not going down, so when we look at that into the future, these cost-saving strategies are there and designed. You're fortunate to be looking at this money that you're getting back from the ESTA funds coming in, and then of course the cost-saving strategies that we are going to talk about a little further there. Those monies are what precludes us from having to go to the well for a rate increase right now. Okay, so I really think we're looking towards tracking towards breaking even, but we start having just a continued long-term period of $600,000-$700,000 weeks. Yeah, we gotta go back to the drawing board.
But Lynn, if you tell me next year the cost of health will cost more, I'd rather you tell me now so I can tell you, well, give me a small increase rather than hit me with a big increase in my health premium. I'd rather take small chunks than hit me with a bag. Because I'm still looking at some of these people that I know they're getting $600-$700 a month in retirement. Now thank God, because I had to read a letter from one lady. The state recalculated, and she was getting $600 something a month. They did a recalculation, and she's going to get $150 more per month. You thought she won the lottery. So now, if you hit her with a large increase in her health insurance, that hits her hard. I think people like her would take small chunks of increase rather than a big hit. Especially if you're telling me health insurance is going to go up.
I don't think there's a person sitting at this table who's going to disagree with that. What we're trying to do is not have to go to the well at all right now.
But you're going to have to
And
go to
when
the
we
well.
do, it should not, because we're always looking at this reporting, because we meet periodically and we're timely and we're staying on top of this, okay, that's what precludes us from not looking at it and then all of a sudden needing a 5, 7, 10% increase, okay? When you're looking at it and you're managing it as timely as we are, unless we had some sudden change of data, and plans your size are pretty predictable as to what's going on. We've been able, if you look at the bottom of this report and you look all the way back to 16 or even 15 here, you're talking about 721, 736, and 16. Our plan cost right now is running at the exact same dollar amount per employee that it did in 2016. Okay?
And Lynn, I tend to agree with you. First of all, I'm very sensitive to the opinions of the teachers, and I know they're very sensitive about, they just got a small pay raise.
Small.
And whenever that happens, it seems as though we come with an increase in insurance. So if we don't have to go to the well, I would really rather not do that this year. You know, and I understand there are years that we have to do that, but it seems to have been a trend, and I know there's a shortage of teachers statewide, nationally. If we start going up on insurance, you're gonna have a hard time attracting teachers if we have some of the higher insurance rates in the district. So I think, and I understand what you're saying,
I
Carol.
just don't want to see.
You don't want a 5 or 7, I don't either,
No,
I
because
agree
we come
with
here and
you.
it looks good, but then we come back and you gotta have a big increase. I don't want
agree.
that to happen.
But if we, you know,
Yeah.
what Lynn is
What
saying.
we're doing
is
right
that-
now lets us stay on top of that.
I agree, thank you.
Glenn, the 20, if you look at column 2019, I'm looking at the 2019 book that we have. This 2019 is from January to September, or it's the same number of months?
The whole year.
No,
Or it's the whole year.
previous periods are all full years. That's why the second page, we utilize the per employee per month numbers to more equalize that and make it easy to compare. So that's why we use those per employee per month numbers. So the summation of it is stable claims increasing some 1.6%. Increased reimbursements of 23%, okay? Fixed cost is stable, lower Humana cost. All of those items put together were basically right under 2% as far as a decrease. But of late, we've seen this pent up demand, so we just have to continue to monitor and manage that. And with that, funding's up 2.8%. So all of that, you know, with the little bit of increase that we're seeing in these last couple of weeks here, and knowing that that's also a combination of summer months trickling in and all of that type of thing, hopefully we go into the fall and have some normalization of the utilization and get out of the summer month periods, which are always high, and we come to some small surplus or break even on the plan. And then utilizing the cost savings from that we developed from the prescription drug PBM marketing, along with those additional fund semester. That's why we don't have to come to the table today and talk about how many percent we're talking about increasing rates right now.
Do we have a total amount that we have saved with Silver Scripts as of October?
Total amount that we've saved from what?
Silver Scripts.
We'd have to compute that. Yeah, we
I'd
can get
love
that
to see
figured.
I was curious if you had the number.
Yeah, and we are, the reimbursements from the Silver Script plan come and lag. So if you guys remember it, they grow, and we're starting to see the larger reimbursements. Some of them are gonna be coming in, some of them have already come in after first quarter and second quarter. But in third quarter and fourth quarter, the funds start to build, and even into 2022, we'll see additional funds come in for Silver Script.
So at our fourth quarter meeting, we should have a better idea of how much we've saved. Y'all can get us that.
January
Oh,
1,
yes, by the
yeah.
end of the year, we'll be able to give you exact figure.
And we're already seeing it. I mean, just on the page 1, you'll see that the plan reimbursements have increased 24.5%, and that has WIP savings in there. So we're already seeing the savings, and they'll continue to grow.
So
at our next
basically, we
meeting-
could kind of compute that right now because we really haven't gotten much as far as specific reinsurance reimbursements. If you go to page 3, you can see under specific reimbursements, we've gotten $209,000. On EGWIP and RX rebates, we've basically gotten a little over $6 million. Okay, so if you take the delta between last year's average of 17 and 86 on plan reimbursement, 17 on retiree subsidies, and you add the 107 plus the 20, the difference between those two numbers multiplied by your participation times 12 is pretty much an approximation of additional savings. Going back to page 3, this just breaks it down by month, and you can see that August month of $3,364,000 of medical claims, $1 million of a prescription, which is about average, maybe a little higher than average. That was a $5 million claims month there, net claims month. And then, of course, right after that, you have September at $2,300,000. And then, of course, we got rebates in of $1,436,000. So, you know, we have a deficit month of $1,312,000, and then a surplus month of $1,148,000. And as Brooks said, we've got a lot more reimbursement coming to the plan. So, with some stabilization of claims and some increased reimbursement, we should be at or near break even, and of course there's a little optimism mixed into all of that as well. Following pages are the same type of report, but on an accrual basis. What you see here is what's reported to us and, from Blue Cross as the claim is paid. Or as the reimbursement is received. This reporting reflects more on an accrual basis or an incurred basis. So for the first 3 months of this fiscal year, July 1st of 21 through June 30th of 22, the first through July through September, we're basically at a $1,338,000 deficit. If you turn the page there, and the page 5 is nothing more than the 2020 year, but I'll show you on the next page, on page 6, it shows that deficit of $1,026,000. When that's measured on the paid basis, it was $1,007,000. So it's just what time frame it actually hits there. From page 7, as far as enrollments and demographics, we've covered this pretty well. We know that our participation is very, very stable. The good news is the membership is not outpacing. Actually, some hiring going on in the oil field industry right now, so we're not seeing a ton of folks migrating over to the plan on that. And that's always something we measure there. Enrollment by plan on page 8. There was migration, and this hasn't changed much from previous report. There was about 5.96% migration to the Blue Saver, and that came from basically a basic plan because the enhanced plan participation is staying about the same. Membership-wise, once again, decreasing a little bit more than the employee enrollment did, so good measure there. Medical claims depicted on page 10. Your 5-year average on your medical claims is 0.31. So just very, very stable as far as that. You can see that, you know, 469, 490, 501, 499. Difference this year is just the claims are coming in utilization, smaller claims, people just going back to the doctor or the facility and having the things done that they didn't have for the past. That increases things just a little bit, and I'll tell you why. If somebody needed some circulatory attention and they weren't able to get that taken care of during the stay at home, that condition might have worsened, and when they're getting that treatment now, it might be a little more serious than it was before. So that is mixed into this data. There's a little bit of that going on. But really, it just points so clearly to pent-up utilization, and at the same time, a pretty significant decrease in about a $3 million+ decrease on our large claims, which really helped us out. So all in all, medical claims decreasing some 1%. Prescription drugs 4.9, and I'll tell you, it's purely, when you see it down the line in the report, in a few pages there, it's diabetes. We've gone from the top 10 medications having 2 meds that totaled about $24 per employee per month. Now we're looking at several more, went from 17 to 24, which is a 41% increase in those diabetic medications. Not in cost, but by in utilization. So that's where our increase in prescription drugs is going. But I tell you, that can be looked at 2 ways. So medical decreased 1%. Pent up utilization, all of that type of thing. It's good that folks are complying to the diabetes medication because it is keeping folks out of the hospital. The diabetes medications aren't inexpensive. It is showing up in utilization on the pharmacy side, but the long term of it is it's less expensive than having a bunch of hospitalizations for diabetics that aren't under control. That can get very, very expensive. Page 13, this is basically, we've kind of covered this. You know, the enrollment on the Blue Saver plan has increased about 6%. It's usually the bottom 3 bullets that we look at here. The enhanced plan has 15% of you people, 21% of the claims. So it doesn't support itself. Basic plan, pretty close to breaking even, 62% of the participation, 66% of the claims. Blue Saver's up to 22% of your participation now and only 0.6% of your claims, so it's subsidizing the other 2 claims. That does not necessarily mean that we want a big, massive push to Blue Saver because Blue Saver also has less contribution.
I was going to say, do we have a number of the decrease in revenue with that?
We did that analysis for you last time, if you remember. The savings were a little more than the loss of contribution, but with the increase of enrollment in that of about 6%, it's about break even. So if we were ever to be, and one day we will, folks, ever to be talking about an increase, thank God it's not today, in premium, we wouldn't be, we would do it across the board even, okay, because albeit the Blue Saver plan is subsidizing the other 2, it still needs to have enough premium to support these folks that are coming on to it.
So that what you're saying is we're saving money in claims, but we're losing money in revenue?
And
so
it's about equal.
Okay.
Obviously, we lose money revenue. One's $10 a pay period, the other one's very far off from that. Total plan cost per employee down at 1.9, and I'll say it over and over again. When you find a plan and you look at this graph and you go back to 2016 at $716 and you look how level that is, and you map it out over those years from an average percentage standpoint, for a plan with over 5,000 employees to stay less than 1% on a 5-year average is hitting it out the park. By type of service,
We fast all into behind our back.
glad you're here. We're on page 15, and this takes us with claims by type of service, and not to be repetitive, but this points to the same thing, because when I talk about higher utilization on claims of 2,000 to 50,000, and then 50,000 being a lot less, it's indicative of that here as well, because you can see your inpatient, where your larger claims are obviously coming from, is down some 20.6%, whereas your outpatient's up 4.5%, and your professional is up about 14.4%. So that really points to utilization versus high-cost claims. By type of diagnosis, from an inpatient standpoint, most of these things are actually down. Injury and poisoning, musculoskeletal down, You've got neoplasm down, which is cancer, and then because some of the other ones are down, pregnancies come into the picture here now. And then the infectious and parasitic diseases down, endocrine metabolic down, digestive down, and then factors comes into it. Really the two that went up are COVID, which is marked as undefined, and then circulatory. But circulatory only went up from 21 to 25. On our outpatient, factors influencing health, and if you remember from previous meetings, a big portion of that is chemotherapy. That actually has come down. Circulatory gone up. Everything else is just about equal with the exception of genitourinary and nervous system. Both of them actually total about a total 145, so that remained the same. Top facilities, first year we kind of had a little flip-flop. And that's only because it's just some of the larger claims and all of that. It's not really indicative of anything, especially with everything that's going on from pandemic and whatnot. You can see that Lourdes is number one when Lafayette has been several years in a row previously, but not much of a big change there.
Lynn, at our August meeting, wasn't Lourdes number one again? Because you had said something about looking at.
So one of our saving strategies, if you remember from the last meeting, was the Blue Connect program through Blue Cross and Ochsner's. And when we went and looked at the additional discount, and of course to get that additional discount, they want you to steer to them from a benefit perspective, and it did not work out to any cost savings there because the additional discount was offset by the additional benefits to steer over there.
Have we approached Lourdes for a greater discount?
We're having, we're talking, having a conversation about approaching both of them. And if we look at the marketplace, it would, and how they're so close. I mean, one's got a PEPM or per employee per month cost of 100, the other one 96. It's not like either one of them's beating the tar out of each other. And you guys are the biggest employer. You're serve the children. And hopefully if we garner just a few more points out of them, that could be a strategy that doesn't affect benefits or anything like that, just giving us a better deal. But remember too, our PPO discounts are pushing 70% right now, so we've got good contracts here locally. When I look at this on some of the other systems, those PPO discounts run more in 60s. Or 58, 60, 62 versus 69, 70%. On page 19, do not be alarmed that you went from 87 to 86%. Who wants to maybe guess why?
COVID.
Vaccine.
COVID.
The vaccine. The vaccine is going to be mixed into these medications, and when both Moderna and Pfizer are in your top 10, obviously they're brand name medications, so it makes the generic number go down 1%. So obviously if we didn't have those two in there, it might have gone up to 88. So,
Do we get reimbursed from the government for the
you do not pay for the cost of the medication, you pay for the administrative cost.
And each shot is an administrative cost, so the 23 and yeah.
Okay.
But I don't think you were here earlier. You weren't here earlier when we said we were reimbursed. We filed for reimbursement for the ASR's grant. We were granted that money of what we spent for a period, and that included some of these expenses of the vaccines.
Great.
And that was part of the money we have applied for in the grant, was the vaccine administration.
Okay.
So all that being 86, 87% of your medications, when you look at page 20, all that generic utilization only amounts to 14% of the money. So that tells you, if you look at it conversely, Your brand name medications are only 14% of your scripts, but they're driving 86% of the cost. Prescription utilization has not changed. We still have 2.8 scripts per employee per month, 1.6. So think about that with all of the membership that you have. Okay, you're averaging almost 2 scripts for every person covered in this plan. Now I can tell you the majority of the people in your plan don't take a prescription drug at all. Okay, so that tells you got a lot of people with a long list of it. On page 22, you see the Moderna and the Pfizer in there, and all of the rest of these are what they're supposed to be. I will tell you that this report looks different from all of the other municipalities that I'm fortunate enough to report on. And I'm going to tell you what's different, and I'm going to compliment y'all for it. I'm going to tell you it has to do with some of the efforts and wellness and different things, and just from an overall process of maybe culture. But I can tell you most of these reports, when I look at other entities, maybe 2 to 3, sometimes as much as 4 or 5 of these top 10 meds are mental and nervous meds, anxiety, depression, all of that type of thing. And there's not a one in here. So that speaks well for this report, real well, especially with what's going on right now. When I look at this on some of the other cases, 3 or 4 of them, and that's not good. And obviously, you know, we always want to push EAP and that kind of thing. Top 10 by dollar amount, once again, this is 2.5% of the prescriptions, 30% of the dollars. Big statistic there. And you can see we went from $90 for the total to $93, so not a big increase there, but a 3.4% increase in our high costs. But when you take a look at what's going up, the Humira is dead equal. It's basically your anti-diabetic agents, the Trulicity, Jardiance, and then the bottom one there, that's a new medication on the diabetic front. So we went from totaling 17 in 2020 on the top 10 to 24 this year, which is a 41% increase in that particular class. Strong PPO number on page 24, right in line with what we were talking about with the hospitals. I mean, we're getting 69, 70, close to 70% there. And then on the next page, 97, 98%. The only reason it's dropped to 97 from the 98 is you had a little more utilization with Dr. Bond. That's a good thing. Okay. Cost breakdown, I have my red note here, says outstanding. When you can run your plan for 8 cents on the dollar, okay? You go to an insurance company and you purchase an individual plan, or if we went to Blue Cross and we got rid of self-funding and we didn't want to take any risk and we didn't want to manage the plan, and we just, Blue Cross give us a rate. In that rate, there would be some 18 to as much as 25 cents on a dollar that's dedicated to running your plan. Y'all are running your plan and for 7.9%. That means most of the money is dedicated to claims. 92% of every dollar funded into this plan are paid by the plan as claims. That's if we can keep that going on, that'll be phenomenal. And of course, favorable renewals this year, so that fixed cost is not going to be having any kind of big impact on our plan this year. Contribution analysis on page 27. Plan cost net of our contributions has come down 3.2%, and that's indicative of a 1.9% decrease in plan costs and about a 2.75% increase in funding. Page 28 shows you what we've been talking about more in more detail, but you can see everything from 0 to 500 all the way to 50,000 increased. Okay, because this is measuring the same period of time, 1/1 through September 30th. Which decreased are our large claims to the point of over $3 million. So the variance from the 2,000 to 20,000 is about $1,762,000. The variance on the 20,000 to 50,000 is about $1,247,000. The variance on everything 50 and over is $3,218,000. So once again, and I know I'm repetitive, but it makes all of this make sense. Higher utilization, significantly lower high-cost claims, resulting in a 1.9% decrease. And that takes us back to our summary. Any questions? Then on our next page, when we talked about the pharmacy benefit analysis, you guys obviously know that your current PBM that you utilize is RX benefits. The goal of the analysis was to review marketplace and get some competitive proposals and negotiate. In addition to RX benefits, they went to several PBM candidates, but they had to have the established record to be able to offer services to a plan of your size in the industry, accommodate all of the things in your plan. They all provided proposals. They utilized the actual claims data. There wasn't any kind of industry trend here or anything like that. Didn't use any kind of claim shifting or clinical program, so it was all apples to apples. Financial methodology to determine it was just take the discounted savings plus the dispensive fees less the rebates. Very, very simple approach to that. What did we get out of this analysis? We were able to negotiate the rebates to be paid earlier, 90 days versus 150 days. We significantly improved the discounts and the rebates. Early pricing relief, actually starting to get some of these savings effective this month versus waiting till 1/1. And the total proposed savings are a little over $2 million, or basically right at $2 million, $2,087,47. So I thought this was, we were very, very fortunate to have some real good minds on our pharmacy consultant team, and they really did some good negotiations on this and came up with some good savings here. So that combination of these savings, which obviously doesn't change a benefit or anything to do with any of what a member receives there, actually just gives us pure savings into the program, and then along with the ESTA funds at this particular time, we really don't have to have a rate adjustment.
So your recommendation, the RX benefits contract ends when?
9/30 is when it ended. That's what he's referring to here.
So
we
this would just be
renewed it.
you
continuing.
renewed the RX benefits
Yeah,
contract?
this is
No.
just continuing on with RX benefits, just to, every year we've always garnered additional savings from them with increased rebates, but this marketing process helped out greatly with that.
So that contract's will
Nothing
be
like a little
renewed?
competition.
Ma'am, say that again.
So the RX benefit contract that expired is being renewed?
Based on the recommendation from the TPA, yes ma'am, with the 2 million savings, yes.
Okay. Then the only thing, this was nothing more than to just give you data that was requested. Remember at the last meeting you wanted some figures on what a premium increase would look like. We talked about a number of different percentages to make it easier on you. I did 1%, and I did what it would mean for you based on your current participation right now. A 1% increase gives us basically $500,000 of additional funding, 509,044. Board share would be 356,673. The employee retiree share would be 152,371. And then you can see in the far right what the actual difference would be on a monthly basis there. And of course, the employee at a 159 on the single going all the way up to family of 288, and then retiree at 497. And then of course, it's for each plan, basic, enhanced, and then of course your Blue Saver plan, and you can see 1%, that's a 10-cent difference in premium. Okay, so this is informational only, that, you know, the 1% increase is obviously not on the table. Thank God for some PBM marketing and for $937,000.
Anyone have any questions for Mr. Fontaine?
I'd like to say, you know, in framing of Carol's comments that, you know, this $900,000 from escrow at one time infusion that will go through the income statement, and it will artificially make this year look good. But remember, you know, next year that 900-something-thousand is not coming. So, you know, we may be looking at something more than we'd like to, an increase if we have inflation of 2 or 3% on $40 million. And we have what we're projecting in the accrual, which is our actual numbers, our audited numbers. We're starting seeing a negative of 1.3 million at this point. So that's the accrual numbers. The actual financial audited report is what is the real number. So we're looking at a loss at this point of 1.3 million. The 900 sets that off to about 200,000.
If you didn't have it, you would have that loss.
And we would still have a loss as of now. Then we add the $2 million savings on top of that. Then when you add inflation, you're kind of back even. But then next year, you're not going to have the 900.
And you're going to knock on my door for an increase. So how much of an increase is that going to be? And then I'm hearing you have not Blue Saver. I just can't think of, that's my 60s moment there. They're not solvent. They're not paying for themselves. The basic plan basically is self-sufficient. But when we have an increase, you're going to increase it across the board, even though the basic is holding on. Maybe the other two are not, but everybody's going to absorb that cost. So again, I'm going to say I'd rather take little bitty hits rather than a big hit with a bat. Food for thought.
None of this is calling for anybody to go to the bullpen and grab a bat.
Not this year.
Not this year. But Matt, what hopefully will offset some of that increase next year, and knowing that we don't have 937,000 coming to us, are going to be those increased rebates in a full year of rebates on the egg whip, and the increased utilization on the prescription drug side will also increase the rebates and discounts there. And then thirdly, and I know this has a lot of optimism in it, but I hope to expect to see some normalizing on this pent-up utilization. I want to get to a point where we see weekly claims runs that are averaging $500,000 and not $650,000.
Yeah, and we see the checks, and it's scary sometimes. You know, we sign them.
You know, you
this
might
for 2
have
weeks?
a claims
You know, I have to
run
process
and
this for 2
we
weeks.
get a large payment in, and
I
it's
call
over
Trish,
$1
I'm like,
million.
what's going on?
So, Lynn, we meet, our next meeting, I believe, is in January, our next.
Yes, ma'am.
25th, I believe.
25th.
Yeah.
Could you possibly have a number of the savings for Silver Scripts for us at that point? And also, to Carol's point, as soon as you all know that we are heading in the wrong direction, if we need a meeting prior to January, as we showed last year, we're more than happy to have a special meeting so we don't get too far in the weeds and end up with
drowning.
a high increase. In August, if everybody remembers, you presented a whole list of cost savings.
Yes,
I think
Yes.
only the last one of which was a premium increase, but there were some increases in deductible, max out of pocket. There were a number of things for us to look at. So I'm asking if you see us trending in the wrong direction between now and January, let's address it as soon as we can rather than waiting until it gets too
Because
bad.
right now, they were given an increase in pay, and once again, it's like there's an increase in pay, the saying is that there's an increase in
Yeah?
insurance, and it kind of ticks the teachers off.
Yep.
So if we could do it, as you said, anyhow, it's April, whatever, but just not have it coincide with that pay raise, so that we know, and then, not only that, but we also need to advise them that there's going to be an increase
It's
because
coming.
of, and I
It's
think
coming.
that's more palatable than just simply, here it is, we need to get it done.
Well,
I
hopefully
think a
we'll
lot
get-
of it has to do with timing, like
Yeah.
you said. It's like-
I totally
And then-
agree.
And then the
Timing,
other thing is, if you're gonna have to do it, you need some justification to it.
yes,
It's the
Right now, just for the
communication,
sake of doing it. I
all
think.
communication.
yes, the communication part of it, yeah.
And the other issue, Lynn, is if we can get this information a little bit earlier,
oh, definitely.
and just so we're all on the same page, had you asked us to vote on a rate increase tonight, I think the majority of the people in this room would have said we can't do it. Because we are all in a position that we're supposed to go back and talk to people we represent and get their feedback. So if it comes that you all need us to do an increase, we need to get that information not 24 hours before. So, okay, next item on the agenda, if there are no more questions for Lynn. Trish, you're up, ECBS Wellness Calling.
Yes, ma'am. I just want to tell you about the postcard that was mailed out to all the retirees with regard to the wellness program, where the deadline is as of December 15th, 2021. We did have Blue Cross in-house today. They were answering some phone calls from retirees who did call in. We probably had about 15 retirees call through asking for assistance, so
Wonderful.
15 more people that got help with regard to the wellness incentive. So essentially, Angel from Blue Cross was here answering calls from retirees who don't have access to a computer or perhaps needed additional assistance, they needed a login, or just help understanding what to do in order to get the credit. They dialed through to our local number, they were transferred to her, and we were able to help several of them today. The biggest thing to remember is our retirees who are under Medicare are not eligible for that $250 incentive. However, we want to encourage you to participate. We want to encourage you to get the physical. We've got resources like that. We typically try and do it spring. I think this year it happened during the summer at BCC. Or you can always see your local physician to get that physical done. Same thing, flu shots and all the other incentives that are listed on that 100 points within that wellness 250 credit. We don't want to discourage you, we want to encourage you to still utilize it. So reach out to us if you need some sort of help with that. But yes, I found it a good resource today. We'll have one more of those offerings on December 2nd from 9 to 3 p.m. during the day. They'll call the same number that they called today, the 521-7066 number, to where we'll patch them through to a Blue Cross representative and they can get whatever assistance that they need with regard to the credit.
Thank you, Trish, very much for doing that, and thank you, Carol,
Yes.
for making
Yeah,
sure that
I'm
we're
happy.
helping
I'm
those folks who
delighted.
don't have computers, because there are
Yes,
a lot
ma'am.
of folks.
Yes.
Those of us who have them, who don't know how to use them very well.
No, that's okay. No, I think it worked out well. So it was a good offering, and we've got one more available to them on December 2nd. So spread the word, remind them that there's still one more offering, and we'll be available to help with it with regard to retirees. Next one, Miss Nancy, you want me to
Yes,
discuss the mail
you're
out?
up the rest of the meeting.
Okay, so Tamara in the office has been doing a fantastic job with sending out all the notifications with regard to the retiree updates. There's about 3,300 of the retirees that we have for LPSS. We've sent out, this will now be our third and final. We're not gonna send out any more. It's been a long and lengthy process that I think has obviously produced good email addresses, good addresses for our records. We're able to update our internal records. With that information, we're able to update Blue Cross, and we're also able to update the US Able Life Insurance, which the retirees have a $5,000 district paid life insurance. So those are the three things we can do with the update. We've sent out the third and final to about 572 members. We've received about 150 of those back. We're still encouraging them to send them through if they got that third and final. So spread the word, tell them we still need their information. If they received a letter from our office, please fill it out and return it. That way we can update everything. The great thing from doing the update is that we now have to date 2,415 email addresses, which equates to about 73% of your retirees. So a lot more people are using that email than we first thought, which is great because that will be a cost savings measure to where we don't have to send out a 3,300 person mail out. It will be not snail mail in that sense to where there's a delay. It will be more efficient. So we're going to use both resources. We've been sending out those newsletters. We've been doing those on a semi-annual basis, and any other communications that we have doesn't become as lengthy now that we have updated email addresses. We're able to use those. So continue to remember to update LPSS insurance if you've got an address change. Encourage your members to do so, especially if they're retirees. They don't always remember about us at central office, but we do need that information. So definitely direct them our way. But it's been a great undertaking. It's been a massive undertaking, but I think it's been a good one.
But I think you all started with zero, and I think it's really going to benefit the system and the retirees, and hopefully we're going to keep active long enough that they'll become retirees.
Oh, there we go. Yep.
But I think it's wonderful that we've been able to get that much data.
Right.
And I wanted to commend that that's all been done by hand. So from the
Wow.
retiree filling it out by hand,
Wow.
so being entered into a system to where we had to build
They had no database, yeah.
groups and a database to be able to get out. So, and that was two people down in the insurance department that they worked constantly to get it up. So they have done an excellent job.
A good crew.
When somebody retires, are we gonna, because right now, I guess all the employees, you send it to the LPSS address. But as you retire, do we get the new addresses?
We've added that to the retirement package. Right.
Right.
So it just rolls over now.
They meet with the retirement benefits coordinator. She goes through all the benefit information. She reminds them if you've got address changes to follow up with us. 9 times out of 10, they're going to update their Blue Cross. They're going to update their pension. Those are their two most important, in my opinion. But hopefully, once they've gotten our contact information, they'll remember that they need to update LPSS insurance too. Okay, so contracts and services. The only thing that is current that needs to be reviewed is the RX benefits that we discussed with regard to Lynn's reporting and the $2 million cost savings. So we're working through that process with RX benefits. So that contract is working its way through to Ms. Trostclair's office and then eventually for a signature. And then the others we are in process of either with HUB or through EBI, our voluntary benefits provider. So they have not been finalized. We're in conversations just trying to fine tune those contracts and to try and make sure we've got everything ready for year 2022. So it's just an FYI, you've got Humana, EBI, the stop loss, and then the Blue Cross Blue Shield portions with regard to the admin services. Yes, ma'am.
I have a question that one of my fellow teachers posed today. It was about dental coverage.
Okay.
And so her question was, is there a change in the provider? And because I did receive a mailer, I get my dental, and I did receive a mailer, and what I understood from it was that nothing was changing. It was just that the provider had been purchased by another group that is going to service the plans the same. Is that a correct understanding?
So essentially what happened is they approved Aflac as the new dental provider starting January 1st of 2022. So when we send out our open enrollment communications, we have made active members aware in particular with regard to the change to dental. That's why we redirected. It was so important for them to talk to EBI this year. That way they were made aware that Dina Dental was transitioning to Aflac. I'm working through, obviously when the committee recommended it, the board approved it. It's a step process. Come Monday, I'm sending out additional communications, particularly to active members first, with regard to the Aflac changeover. It's gonna have more specifics, because now we've migrated from the contract being approved, and we're now starting to get website information and other things. So I'm gonna send out that communication to actives. That way, if they need to make any changes to dental, they can do so prior to the end of open enrollment. They would still have 2 full weeks to make a scheduled appointment with EBI, and should their dental provider, and they don't want to stick with Aflac, they can certainly call EBI and cancel that dental prior to the end of open enrollment. And then we are also working through the process with retirees. We're going to have a communications piece to them too, on everything Aflac, so that they too are communicated and they're in the know, and they can make sound decisions with whatever changes, whether they want to stop it or whether they want to continue the service. That way they know how to get provider information, whether they'd have to file a claim form. We'll have everything available to them, and we're going to do a mail out and an email to retirees too. So, but my active members, I'm pushing that out first, simply because we want to make sure that they have an opportunity prior to the end of open enrollment.
So simplistically, if you're with Dina Dental, the dental that we have, there is no change?
There is no change to plan benefits, absolutely none. It's going to roll one plan benefit to the other. No benefits are changing. Cards will change. That will obviously be different. There was a 4.25% increase with regard to premium with active members and some retirees in particular. The grandfather retirees, they saw a reduction. They will see a reduction in their premium.
But they can keep their dentist.
Yes.
The
Well,
providers, yeah, that's what my
I'm going to
question
give
was.
specifics with regard to that. That way you can check your provider. The key here is that a lot of members were going out of network. And that was what's causing issues with regard to when contracts come available for negotiation purposes, for members when they go see their dentist and they have to pay out of pocket, them perhaps not having an option with regard to ortho and surgeries for wisdom teeth. There weren't options available to them. So by the change to Aflac, the difference was that they were expanding the network. That was the main factor involved in it, and it wasn't as much of an increase. Dina Dental was offering a 10%, Aflac was offering 4.25, if I'm remembering that correct.
But we went into that in detail during the last meeting.
Right.
Yeah.
Okay.
But I'm gonna give a lot of details, because if your dentist is out of network, that's where we're gonna have some options and information on the communication piece. We can petition your dentist to join the Aflac network. So I'm gonna have all the information on the communications that we're gonna send out to both active and retirees, giving you steps on what you can do, giving you resources as to where you can look for a provider to see if your dentist is in network.
So a dentist, so you may have to change dentists?
If they're not in network. If you don't want to pay
But that's gonna
out
be
of
on your
pocket
correspondence.
costs.
Right.
That's gonna be on the correspondence, the list of providers, is that gonna be on
It's
your
gonna be a
correspondence?
link, yes, and then for retirees, we're gonna send out that link within the email communications, and I'm gonna redirect on the postcard or either a letter mail out to the retirees that will have a go-to to where they can get that information.
But the network's going to expand.
Right,
rather
the
than
network will
contract.
The
expand,
chances
correct.
of your
That is
dentist
right.
currently that is not maybe in the new one is better. And I think that was clear when we made the decision that the greater network and the lower price was the reason to go for a change. And when she says transition, it's not a buyout, and I can see how that terminology would.
I just got I got a letter from Dina Dental. I got a letter from the Dina Dental company that said that they were purchased by another company,
Oh.
but we're still gonna, and so that my friend had asked me this thing about Aflac, and I was like, what? You know, that was
You're
my
right.
confusion, because I I didn't get communication from y'all, I got communication from the other insurance company. And then I got this other question about dental insurance, and I just wanted to make sure I had everything straight.
That was the reason why we were emphasizing to the active members in particular to make their scheduled appointment with EBI this year for open enrollment. That way they could receive that notification. We didn't want anybody blindsided. We knew that we were going to do internal communications from insurance. We knew that was going to happen. It's just taken just a bit to put all the puzzle pieces together. That way we can communicate what we need to. But it's coming. I expect the email to go out from me on Monday the 1st.
Trish, I do have a quick question. If a retiree is not currently, or does not currently have dental insurance, they're not allowed to jump on this plan.
No,
They've
ma'am.
been grandfathered in, right?
Exactly. You would have had to have
I just
had
have to
it
make
at
that
the time
clear.
of retirement.
Right.
Retirees cannot add.
Okay.
However, active members can.
Right.
Right.
Okay.
Last thing, Trish, fund balance.
Okay. So, based on the
Oh,
information.
I'm sorry, Bud.
Okay.
Let me make a comment. On my particular dentist, what happens is that when I go, basically it's Dina, and we do the process, and they send me the bill. They file it. With the changeover to Aflac, I was informed that I have to pay up front, and then they'll give me the paperwork, but they will not file like they used to do with Dina. So it might behoove our members to go ahead and check before the change to see what their dentist will or will not do.
And we're realizing through that process that it's for the most part based on the dental office. I'll give you an example.
Yeah, I know. I understand that. But what I'm saying is that, if had I not known that, I'd just gone in and said, well, just charge it. Okay, well then, you can't leave here without paying. So I'm going, whoa, wait a minute. Normally we did this, and so that's changing. So
And it almost sounds like your dental office may not be a network based
and
on what you
I
just
think
told
you're
me.
right about
Yeah.
that. But as a complimentary thing, that they went ahead and they would
Right.
file with the insurance, let them pay, and then send me the bill.
Right.
This will not happen anymore. I have to pay it up,
Well,
and I have to file it, and they'll just simply reimburse me.
some dental offices are, because we've got an employee in our office, the exact same example. Her dental office is actually out of network with
Right.
Aflac. However, she's an existing client, and they said because she is, they would file on her behalf just like they did previously with Dina. So I honestly think it may be a case-by-case dental office by
Could be.
dental office, but we can still work through that process of reaching out to the dental office to see if they would be an
Yeah,
in-network
that would be great.
dentist for Dina.
That would be
The communications that I'm gonna send is gonna have that instruction.
Okay.
If you get a hold of your dentist and they say that they're out of network, then give us a call and we will reach out and we'll have Aflac reach out to the dental office.
Can't get better than that. That's cool.
Fund balance, Trish?
So it's the unaudited fund balance. We started off the fiscal year with $3,680,423 based on the data that's provided from HUB from July through September. It brings the fund balance to $2,341,606, and keep in mind that's unaudited.
Gotcha. Thank you very much.
You're welcome.
Bush, we've got about 9 minutes.
Woo, okay.
I'll move.
I was waiting for you to do.
I would love to, Clyde, but.
You just want to move is what you want to do, huh?
You got something to say, Buck?
Well,
Butch has 9 minutes to make a
What are you
presentation.
gonna do?
okay, it might be a cost savings for you, okay? I'm on medication, and the medication basically is ongoing. It's always been a 90-day script. But I found out instead of going for 90 days, I went for 180 days, okay? And I'm saving some money through the drug plan simply by going to the 180. Now, some of the pharmacists don't like that, but it's helping me because I've found that in some instances, maybe for $3 more, I can get another 90-day supply. I have some figures here, and this is through Good RX. There's another one with Savers. Okay, well let's just take that.
I'll let you talk about that.
Okay, cool.
Look, do you have mail-in on those 180 days?
Basically what I did was, I went to the doctors and I said, okay, I need a script for 180 instead of a 90-day script. So they wrote it out and I explained what I was doing. So with that, I went ahead and you can see what happens when you go to the website for like GoodRx, or there's two more that I have, and there's even some more that I'm hearing about. There's something called RX Saver and Single Care. And what I did with the spreadsheet here, basically, I gave you a 90-day and a 180-day cost, okay, on and I didn't say what drugs they were. Some of them are listed on the ones that we just talked about just a minute ago. And basically, I mean, the savings are unbelievable as compared to just doing the 90 days. I mean, for example, let me see if I can give you one. Okay, look on 10/25/21.
Good.
All right, the 90-day script would be $13.85. Okay, on the Albertsons, and then if I do a 180, it's $3 more.
Yeah, that's not bad.
Okay, $16.60.
That's a no-brainer.
That's a no-brainer.
It's not
Now,
bad.
some of them are pretty close. They almost double the price.
Yeah.
But on some, and this is just some, okay? And it's the drugs that I have here. You may be in an entirely different situation, okay? But I did find, and then look, some of this stuff, like, it'll go for 360 days, okay? But, and it's even cheaper. That might be $2 more. But what I found, I didn't go more than 180 because I go to the doctor for a normal, regular checkup every 6 months. And I think that's probably normal. So if there's a change in medication, I don't want to have too much more than I really need. So I opted for the 6 months. But if you look, there are changes, and the changes can occur daily. So you go to the website, you can get the coupon, bring the coupon to the pharmacist, and hey, this is it, Jack. Now, when they get on there and they do it, there may be a slight change, but it's not going to be, dollars and dollars.
You came out of pocket for this, right, Butch?
Yeah, you do not use our insurance.
All right, see that?
This is, no, you're going to pay anyway.
Right.
You either pay the $30, that we normally do, or you just simply pay whatever it is. Let me show you the difference. Well, in fact, if you look at the 2 pages on the back side, this is a drug that I take, and I need a 75 milligram tablet. Well, the company makes a 25, and they make a 50. So I'm paying full price for 25, and I'm paying a full price for a 50. But look at the difference in the prices as far as the companies. Okay, we have over here, like say on the 25 milligram for the 90 tablets, it's $24 at Walmart. Now, I've been saying this for years. You can go to Walmart, and for some of the drug, not all, but they have a standard price. It's $10, and it's cheaper than using our insurance and just simply pay the $10 instead of the 15 or the 16. Look at the difference in cost. Here we go with now Walgreens is, I found, the highest. Always, 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 for some reason, they're the highest. Here's a drug you can buy for a low of $13.85 and a high of $34.45. That's a lot of money for some people.
Yeah, it is.
And then if you go to the 180 tablet, let's look at, and this is the same thing, 25 milligrams.
And you can use coupons.
And these are coupons. Now, if you can, it's a coupon.
That's coupons.
Okay. And what
I'm
happens?
gonna pass this on, but.
And what happens? You can order a card from the particular company. Like I said, there's 3 of them right now. I listed them on the spreadsheet. But if you look here, okay, let's say for example, let's look at the Albertsons right here. Okay. Well, I have it actually on the. This is drug number 7 on the spreadsheet.
Oh, 7.
That's drug number 7. These are the different prices that are for that particular drug with a 90-day script and a 180-day script. Now, I have one, number 4, that I have to take 2 times a day, so it has to be 360 pills. But it's just something for you to know, not to say it's good or it's bad. For me, it's good. But it's something maybe we need to let our people know.
Now, if you had to use your prescription, Silver Script,
Oh, you
how
have,
much more?
no.
I'm not saying, have you done the comparison with Silver Script, the cost of Silver Script
Okay.
versus this? I'm asking.
If you look over here, which says current 90 day, on the top part, on 7/16/21,
Yes.
okay, this is what I paid for my local pharmacy.
And that's
Okay.
using Silver Script or that's using RX?
That's using
benefit?
Silver Script.
So that's what I'm.
All right, so if you look here on let's say drug number 7,
Okay.
look at the first one on 7/16/21.
Uh-huh.
Okay, my pharmacist charged me this. That was my copay,
Okay,
$21.59. But I could have gone to Albertsons
and got,
and got it for $13.50.
gotcha. Okay.
Go big.
So Albertsons is really,
Albertsons, okay, and now I will tell you this, believe it or not, Super One has some really good prices.
Yeah.
But then again, if you want to really shop around, and I looked at them, I'd have to be going to 3 different pharmacies to get the best price of all. So I figured, well, a couple of dollars more, I didn't put it in gas, I just let it be in one place. And that's what I've done. I went ahead and changed over everything, because my local pharmacist doesn't take like the good RX. Now, what I found interesting was that on RX Saver, if you go on the website, they'll have other pharmacists, and my local is there, and it's cheaper than what I was getting or would be getting at some of the other ones. So it's like, this is crazy. The drug prices are absolutely crazy, and they're getting. We can save money, but we have to be, wise consumers. And pretty much, it's just like, I had nothing to do, as you can tell. I mean, and so, but man, my eyes were crossing by the time I got through with all this.
Instead of shopping for car insurance, you're shopping for the best deal on the prescriptions.
Well, it's just, when I'm looking at this, and we have people that don't have a comma in their check when they get it, okay? And when you're looking at that, and older people, look, hey, those younger ones are gonna get old. And
That's right.
you guys will too.
And they're gonna have to go through
And they're just things that happen. We weren't working. You know what the saying is? Had I known then what I know now, I'd have taken better care of myself.
Yeah.
But
Thank you, Butch. Thank you very much for all
you
your
got
I would like to.
I think so
Motion that we
much.
adjourn this.
Can I second that motion?
Rod, Terry, and Butch.
Yeah, I have.
All those in favor of adjourning?
Aye.
Opposed? Next meeting is already scheduled. It's in January